Okay, good morning, everyone. I'd like to thank the organizers on behalf of my colleagues at ViiV Healthcare and GSK for the opportunity to present these data looking at the response of dolutegravir-containing regimens in the context of less than fully active background regimens. Dolutegravir has exhibited potent antiviral efficacy in phase 3 studies of more than 1,800 integrase-naive patients. All subjects enrolled in these studies were screened for resistance. Those who were detectable resistance for RT or protease were excluded from enrollment in the treatment-naive studies. Baseline resistance in the saline study, which is a study of treatment-experienced but integrase-naive subjects, was performed and used as inclusion criteria and to select the background regimen for use in the study. Today, we're going to present some additional data from some post-hoc analyses of virologic failure based on background regimen and baseline resistance from the saline cohort. This slide summarizes the efficacy results and the virologic failure results of the phase 3 studies in treatment-naive individuals across the dolutegravir program. The Spring 2 study and the single study have 96 weeks of follow-up reported, and Flamingo has 48 weeks. You'll note that the percentage of subjects achieving less than 50 copies per mil across the 3 different studies demonstrated dolutegravir was non-inferior to the comparator arm, and in addition, in a pre-specified analysis, dolutegravir was shown to be statistically superior to the comparator arm in both single and Flamingo. In terms of protocol-defined virologic failure, or PDVF, the definitions are included in the references at the bottom of the slide. There was approximately 5% of subjects across the 3 studies in both arms that had exhibited protocol-defined virologic failure. In the dolutegravir-treated individuals, there was no treatment-emergent resistance detected through either 96 weeks in Spring 2 and single or 48 weeks in the Flamingo study. Conversely, there was resistance detected to both the third agent and the nucleoside backbone in the Spring 2 and single studies. Now I'm going to transition to a few data on the saline study. Again, the previous data was on treatment-naive individuals. This data set is based on subjects who are treatment experienced but are integrase inhibitor naive. This is a blinded study where subjects were enrolled based on the criteria in the gray box on the left of the slide, having resistance to 2 or more classes of antiretrovirals agents, and as well as being able to conduct a background regimen of 1 to 2 agents with at least 1 being fully active. We have gotten questions at times about the response rate and the failure rate in subjects with less than 2 active agents in the background regimen, and some of that will be addressed in the post-hoc analyses presented. Subjects were randomized to dolutegravir once daily or raltegravir twice daily, and the week 48 less than 50 response rate was 71% for dolutegravir and 64% for raltegravir, and a pre-specified analysis showed statistical superiority for dolutegravir with a p-value of 0.03. In terms of resistance, there was significantly less resistance by predefined analyses at PDVF in the dolutegravir arm versus the raltegravir arm through week 48. In addition, a further context regarding the use of boosted darunavir in this study. You'll note that approximately 60% of subjects on the first line did not use a darunavir-containing protease inhibitor-based regimen. And of the 214 dolutegravir subjects, 67 subjects achieved less than 50 copies per mil by week 48, and 126 of 209 for raltegravir. And you'll note in red the text showing that darunavir use in the presence of primary PI mutations, there was a statistically different response rate, with dolutegravir having an 85% response versus 67 for raltegravir, and the confidence interval did not cross 0. And then darunavir use without primary PI mutations, the response rate was comparable between the 2 arms. Now I'm going to switch gears a little bit. Instead of presenting the less than 50 copy FDA snapshot analyses, we're getting into the post hoc analyses now of protocol-defined virologic failure rates. This slide shows you the summary. Again, 21 or 6% of subjects versus 45 or 12% of subjects on raltegravir had protocol-defined virologic failure in the sailing study through week 48. For those subjects that had an NRTI-only background regimen, there were no virologic failures in the dolutegravir arm, and 7 out of 32 in the raltegravir arm, and 6 of these 7 had detectable integrase resistance seen at the time of failure. The majority of subjects had PI-containing background regimens, and this is where the highest number of virologic failure was detected in each arm. And other background regimens, including, for example, Maraviroc and T20, et cetera, there's a small number of subjects there, 3 and 2 in the 2 arms. A little more context on those subjects with the NRTI-only background regimen. You'll note here that the majority of subjects had either 1 or 2 fully active NRTIs present in their background regimen. And then a little bit further context here. When you consider that some of the subjects that enrolled in the study had M184V detected at the time of study entry, in clinical practice, it's not uncommon for these types of patients to be receiving perhaps a boosted protease inhibitor along with 2 NRTIs, either including 3TC or FTC. In the sailing study, these patients would have received either raltegravir or dolutegravir plus FTC or 3TC plus a second NRTI. As you'll see here, there were no subjects that had virologic failure that met these criteria in the dolutegravir arm versus 4 in the raltegravir arm. The majority of subjects had a fully active second NRTI by phenotype, and there was absence of TAMs, again, in the majority of subjects. In terms of the overall population that had TAMs detected at entry, all patients with TAMs, there was 6% virologic failure for dolutegravir versus 10% for raltegravir. And then when the patient had TAMs and received a less than fully active second agent NRTI, either abacavir, tenofovir, AZT, or DDI, you can see the rates there, 3 of 24 versus 1 of 19. And then the majority of those subjects were receiving a protease inhibitor as the third agent. In terms of the impact of protease inhibitor regimen in the context of virologic failure, there was lower virologic failure in those subjects receiving dolutegravir, 6% versus 12% for raltegravir. This is regardless of the number of the fully active PI or the PI being used. Darunavir was the most commonly used agent in the study. Susceptibility or activity, if you will, was defined by the monogram PhenoSense assay as well as the genotypic testing based on the Stanford algorithm. Conclusion, there's no resistance detected to dolutegravir or the 2 NRTI backbones of either abacavir 3TC or tenofovir FTC through 96 weeks in Spring 2 or single, or 48 weeks in Flamingo. In the sailing study, again with the treatment experienced integrase-naive subjects, for those subjects who did not have a fully active background, the data show that dolutegravir plus 2 NRTIs was not associated with virologic failure in those small number of subjects. So with that, we would say that further studies with larger numbers of subjects and longer-term follow-up would be needed to really understand the activity of dolutegravir-based regimens in these types of patients. And finally, I just want to say that the resistance profile for dolutegravir, like any new agent, will be defined further by use in clinical practice, as well as additional ongoing and yet to be started clinical studies. Finally, in terms of acknowledgments, I would like to thank the patients and their supporters for their participation in these studies, the dolutegravir study investigators representing many sites globally, the study teams and colleagues at ViiV Healthcare and GSK, and in particular David Dorey from GSK Statistics, who did a lot of the post hoc analyses presented today. And these studies were sponsored by ViiV Healthcare. I thank you for your attention and be willing to entertain questions.
Thank you, and we have plenty of time for questions. Yes.
Oh, thank you.
Can I just, can you talk a little about the resistance that did occur in patients in saline in those who did fail?
Sure.
You talked about the lack of resistance in the naive studies, but.
Yep. So in the raltegravir arm, the resistance in the integrase gene is typical, the 140, 148, 155, et cetera, mutations that one would typically see, as well as some in the background regimen. The background regimen is a little harder to obviously sort out because of the complexity of the treatment history. In the dolutegravir arm, there are 4 subjects identified to date. One subject had a treatment emergent V151 VI polymorphism, and that subject had never suppressed below 90,000 copies per mil on treatment. Another subject, and there's also one subject in the raltegravir arm that entered actually with pre-existing integrase resistance. The person in the dolutegravir arm had a 148 pathway virus, and in the raltegravir arm, a 143 pathway virus, so they had pre-existing resistance there and received once daily dolutegravir. And then there were 2 subjects. One had a R263K mutation detected, and the other had a R263RK mixture that was detected. And that's all we have seen at this point. And again, in this study, the viral load criteria was 400, and all samples were evaluated, and just like there were in all the other studies.
Thank you.
Okay. Thanks,
Okay.
James.